Good morning. Welcome to the SCMR 2022 Symposium on AI-Assisted Cardiac MRI. My name is Bob Hu, and I will be your moderator today. My conflict of interest are that I'm the Chief Medical Officer and co-founder of Harvista. I'm joined today by two well-known folks, I think, in the community. Dr. Michael Salerno, who's the Director of Non-Invasive Imaging at Stanford University, and Raymond Kwan, who's Professor of Medicine and the Director of Cardiac MRI at Brigham and Women's Hospital. I'm joined on the executive team at Harvista by Dr. Juan Santos and Dr. Bill Overall, who are my co-founders, and Itamar Kandel, our Chief Executive Officer. I think the medical and scientific advisory board members are well known to the community as well, who obviously represent a very substantial contributions to the field of scientific and clinical investigations. So what is the promise of MRI? Well, the idea of a one-stop shop so that we could evaluate all aspects of the cardiac function has long been the goal of cardiac MR. And we would like to provide this in an accessible way, affordably, and with high degree of accuracy. So what stops us from doing this? Well, the problem is complexity. There is upwards of 300 clicks needed for a cardiac examination to tune all the necessary imaging parameters. And this typically then lead to scan times that could be upwards of 90 minutes per study. So our solution is to simplify the situation through control of the hardware and automation. We have control of the MRI hardware with collaboration of our corporate partners, and we achieve automated scanning through machine learning technologies. So here's an example of the AI-driven toolkit that we employ. We roughly divide it into 4 parts: the planning stage, a tuning stage, a monitoring stage, as well as an analysis stage. We first acquire the images at the desired plane locations through a set of neural nets. We then have a second set of neural nets that help us do tuning of the individual sequences that are selected. And then the images are examined at a monitoring stage for artifacts and other corruptions of the data. Finally, when we have an image that's taken at the right plane with the appropriate parameters, with adequate image quality, we assess the studies for adequacy of an overall data set for interpretation. So the idea here is, of course, to one click and forget it. And here I'm going to show you the process of localization. So as you can see, the images initially start in the abdomen and the heart, and the machine search for the heart. Once it's found the heart, it's looking at the appropriate imaging plane, which to take the next set of images. And here it is, the long axis image. And then once it acquires the long axis image, it looks at that and decides on where the most appropriate short axis image ought to be taken. And then from there, prescribe the 3-chamber, 4-chamber, and so forth, based on all the previous information. The rest is just stamp collecting. No. Obviously, being able to achieve this initially is not quite enough. And what's needed is to actually acquire the data in such a way that we could evaluate the adequacy of the overall system. So here we start with plane localization. What we did here was to take images that are acquired both by humans and by machines and have them reviewed separately by a blinded observer who is asked to judge on the adequacy of the plane selection. And as you can see, 92% of the human and 90% of the machine imaging planes were felt to be adequate, which is statistically the same. We then look for image optimization. Here I am again using LGE as an example, where the machine is able to pick out the appropriate inversion time for the study. But of course, an interesting thing about image optimization in LG is that you will sometimes have failure modes, such as this, in the case of cardiac amyloidosis. And obviously, there is no appropriate or optimized inversion time for this. And so the machine has to recognize this and then revert to a fail-safe mode to complete the examination autonomously. And then there's the image quality assessment. Here we show you motion-related artifacts as an example. And in this case, the machine has detected that there is motion artifacts and pauses to ask the user on whether to rescan or to accept the adequate quality of to accept the images and proceed. So once we're able to do all of those, as I said, next we take that image data and start to do some limited online analysis. And the purpose of an online analysis is to allow us to perhaps reprotocol the study to acquire additional information should, say, unexpected wall motion abnormality is found, or an explicit flow signal is noted. So the initial clinical experience was conducted by two trained cardiac MR technologists at the Palo Alto Medical Foundation on a GE 1.5 Tesla system using version 2 of our FDA cleared software. Version 3 is now cleared on both the GE and Siemens platforms. And the technologists, I want to emphasize, can also drive the system completely manually if they so choose. We currently have about 800 plus patient studies that have been done using this approach. And the population of patients has the usual indications for cardiac MRI. So here's a typical vaccine myocarditis example. It's a 24-year-old woman who presented with chest pains and a previous COVID-19 vaccination within 3 weeks of the study. Initial evaluation included a minimum troponin elevation 0.2, and a cardiac MR was interpreted as normal at a different hospital. A subsequent cardiac MR examination was done at Palo Alto Medical Foundation. The troponin then rose to about 17 a few days later, which peaked eventually at 120. Here is the wall motion study, where it's a somewhat reduced EF about 40%, and incidentally noted to have ventricular non-compaction that was missed previously. We typically do a full flow mapping, qualitative flow mapping to assess for occult flow signals that might be important in the evaluation of these patients. Here, of course, is the typical myocarditis findings on delay enhancement with epicardial uptake of contrast. And the typical parameter mappings are also done. In this case, T1 is elevated, and T2 at the time of this particular examination was normal. Here is a summary of the recent 100 consecutive myocarditis patient studies, where you can see that the average scan time was 38 minutes, given the protocol that does all of the things that I previously mentioned, with a standard deviation of 6.9 minutes. Some of the outliers here were for bathroom breaks, which I guess we still can't quite automate away with artificial intelligence. As a comparison, some preliminary aortic and valvular experience, the recent 30 cases show that this is a semi-automated examination because the parameters for flow is not yet automated. The protocol consists of SSFP, LV function, flow imaging, quantification of the heart valve and gray vessels, along with contrast enhanced MRA. Delay enhancement is obtained if there is the presence of abnormal LV function. The average scan time here is 28 minutes, and with a 9.7 minute standard deviation. There are some unintended consequences once you're able to image with some leisure on the part of the technologist. For instance, here, it took about 12 minutes to acquire the qualitative flow mapping. And basically, they weren't under a lot of time constraints. And so they were able to just spend some time and look. And obviously, this means that we probably should be shortening the time allotted for the examination. I also found incidentally that one of the technologists created a new protocol, which is a 15-minute ischemic examination with mapping. He noticed that we were doing a lot of mapping sequences and thought that maybe we acquire some extra maps on all these ischemia patients would be a useful thing to do. Currently, we have more than 30 FDA cleared sequences to build your own AI-enabled protocols. We have partnership with on both the Siemens and GE platform. And most recently, we also received approval from the FDA to control Siemens sequences through their XSI interface. So in conclusion, automated quantification and industrialization of the cardiac MR scanning process is now here. And that the age of improving cardiac MR affordability, accessibility, and accuracy through machine intelligence is beginning. Thank you very much. And I'd like to turn the meeting over now to Dr. Salerno. Thank you so much.